Okay, so now we move on to the acute coronary syndrome, and there is a definite role of statin in acute coronary syndrome, particularly high intensity statin. So, for that, I invite Dr. Rakesh Gupta to speak on that.
Good afternoon, everybody. I think we are the fag end of a day, like talking of this kind of a topic, which was posted for yesterday, got delayed to the almost the ultimate day. How do I really put in my life? If you have a statins, it is the same variable history as a beautiful, tall, slim, extremely fair and sexy girl who wants to get married. This is what statins are. Tons of data, tons of literature, and on top of that, you have to choose which one to and how to choose. There's a long history of statins. If you happen to read this kind of an history, starting from way 1900, going onwards towards till 1995, 1998, and finally 2014, when all people, they talked of only one thing, that was statins in coronary artery disease. Well, many literatures, many landmark trials made a difference, and couple of them I like to elucidate one. One was the most important trial, was the Forest trial, where over a period of 6 years, simvastatin with 100 patients with coronary artery disease, they saved 4 deaths, 7 MIs, 6 revascularization process. Just a trial which made a difference in mortality and morbidity. Second was VOSCOP study. Same thing, if they gave a statin, it made a lot of difference in this literature. Escort LA trials talked the same kind of a thing, so was the Prosperous trial. And these kind of a trial, along with the heart protection study, made lot of difference that statins are useful in cerebrovascular and coronary artery disease. This is one study, many people have quoted this study, in last 1.5 days, in Meteor's trial, first statin to show a treating dyslipidemia with rosuvastatin, it halts a progression of atherosclerosis in low-risk subject, leading to US FDA approval for atherosclerosis indication. On the contrary, other side, Asteroid, 4 out of 5 patients showed coronary plaque regression in patients with established coronary artery disease. And take my word, this is only one statin, rosuvastatin, which has shown not only regression of atherosclerosis, but reversal of atherosclerotic plaque when it was used in couple of studies. One trial published in 2005, cholesterol trialistic collaboration, which was a meta-analysis of a dyslipidemia trials. Simple, one word I'll say, significant reduction in major vascular events when these statins were used. Similarly, when we had a relationship of LDL cholesterol and progression rate, all these trials together, they said, if you reduce your LDL level to significantly low level, as we have been listening from last 1.5 days, is will lead to a reduction of a cumulative events because of a significant reduction in atheromatosis plaques. Meta-analysis of all intensive statin therapy, and if you look at the hard points, whether it's a coronary death, any cardiovascular event, cardiovascular death, non-cardiovascular death, and total mortality, and a stroke, if you use a high dose statin, they're always better in comparison to placebo. But what all trials which made a difference and let the people wake up, look, they are useful in secondary prevention. There were a couple of them like Miracle, A to Z, Prove It, and Improve It. These were the 4 trials which really made us to think that these trials are useful. I'm not going to go the details of this Miracle trial. Significant reduction in recurrent ischemic events in the first 16 weeks, mostly symptomatic ischemia requiring hospitalization. And as Dr. Thakkar told about a couple of minutes back, if you have a CRP level which was more than 2, LDL level more than 70 versus CRP level less than 2 and LDL level less than 70, look how much is the cumulative mortality, probability of death and MI, you can see very well in this graph. Then next is a proven trial, 4 months LDL, long-term risk of death and CV mortality. If you happen to look at this kind of a slide, lower the better it is when we use it. And the further one, once we talk of all these kind of a trial, is from prove it to improve it is lower the better it is. And we have been discussing all this for last 1.5 years. Look, it was 70 earlier, now to a large consensus we can say it has to be between 40 to 50 from person to person, organization to organization, census to census, and association to association. Let's look at a journey of trials for acute coronary syndromes. This is first in 2004. Early intensive versus delayed conservative simvastatin strategy in patient with acute coronary syndromes. And if you happen to look at this trial, placebo versus simvastatin. If you use a high dose simvastatin, the cumulative mortality is significantly low. And it categorically says that higher dose of a simvastatin significantly reduces secondary events. Another trial in 2004, intensive versus moderate lipid lowering with statins in after acute coronary syndromes. Look at the 40 milligram of pravastatin versus 80 milligram of atorvastatin. So higher the dose and better is the outcome in secondary preventions. And next comes another trial which I've showed you before also. The CHD events rate in secondary prevention ACS trial is, and if you look at these kind of a trial, the lower the LDL level is, the less is considered a coronary artery disease events in secondary prevention is. In 2005, another trial was published, early to late benefits of high dose atorvastatin in patients with acute coronary syndromes. Same 40 and 80 milligram of pravastatin versus atorvastatins, which led to significant reduction of these kind of incidents subsequently. 2006 saw another trial talking of intensive statin therapy and risk of hospitalization of heart failure after acute coronary syndrome, that's PROVE IT and TIMI-22 studies. It says that again, pravastatin versus atorvastatins. And it's not only that, looking at the BNP level, if the BNP level is more than 80 and BNP level less than 80 with atorvastatin, the significant less chances of heart failure and hospitalization subsequently. And this trial category says that intensive statin therapy reduces the risk of hospitalization for heart failure after acute coronary syndrome, with most gain in patients with elevated BNP levels. In 2006, another trial we saw that meta-analysis of intensive statin therapy in acute coronary syndrome, whether it's 1 month or 24 months, there was significant reduction in a cardiovascular event in these subset of population. Another trial, ACS patient major coronary events in 2006, talking of simvastatin versus atorvastatin. Again, atorvastatin proved to be a significant reduction of almost more than 34% of reduction in cumulative hazards in these kind of groups of patients. And where we can really play a significant role. Early intensive statin treatment reduces heart cardiovascular outcome after acute coronary syndrome. And if the same study says that early intensive treatment with atorvastatin is efficient intervention to reduce hard cardiovascular events. Well, all these statins, are they good? Dr. Aditya Kapoor was very emphatic in talking of hepatic, muscular, cognitive, diabetic effects of these kind of things. Do we have any literature talking of all these kind of things? This is one paper from 2014. This is a Cochrane library talking against statins. They says that in author's conclusion, based on the moderate quality evidence due to concerns about risk and bias of imprecisions, initiation of statin therapy within 14 days following ACS does not reduce death, myocardial infarction, stroke up to 4 months, but reduces the occurrence of unstable angina at 4 months following ACS. In plain language, they very categorically said that we did not find any significant risk reduction in all-cause mortality, heart rate, stroke within first 4 months of a high-dose statin therapy. Another paper from European Cardiology Group in 2014, talking of a risk of a diabetes. Meta-analysis of statin outcome trials have confirmed that statin use associated with greater incidence of new diagnosis of diabetes, with evidence that this association is stronger in patients treated with high dose of a statin therapy. We have deliberated a lot in last 1.5 days. The risk of developing a diabetes is one where you can save almost 6 subjects from an onslaught of a cardiovascular diseases. If somebody develops a diabetes, we have a chances of maintaining a diabetes and at the cost of saving 6 people. And this paper category says that now the people develop diabetes, we really should continue managing these people with high dose of diabetes. This is a very eye-opening paper from BMJ Open. It says that effect of statin on average survival of randomized trials and analysis of end point postponement. I was trying to read what do they mean by end point postponement. What is end point postponement? Death. And that's what Dr. PK was saying. Does it make any difference for an end point postponement? Believe my words, whatever I read in my literature, it does not do anything with the end point postponement. It reduces morbidity and other things. As far as mortality is concerned, is not going to make any difference. Statin treatment results surprisingly small average gain in overall survival within a trial's limiting running period. For patients whose life expectancy is limited or who have adverse effect of treatment of withholding statin should be considered in this subset of population. Well, it's not only the foreign word, is the Indian literature also talks something different when we use these kind of a statin in our own country. High versus low dose of a statin therapy in Indian patient with acute ST segment elevation, myocardial infarction undergoing thrombolysis. This is a paper published from Rajasthan. It categorically says that high dose atorvastatin did not show any difference of MACE in STEMI patient undergoing thrombolysis, but showed significant improvement in immediate coronary flow depicted by ST segment resolution. This benefit of high dose statin is to be weighed against greater myalgia, drug discontinuation, and cost of Indian patients. This is one paper in Indian literature published in Indian Heart Journal talking of the thing not by intervention, by thrombolysis. You look, these patients, they did not make any difference. And that's what their graph says, whether you give atorvastatin or whether you give placebo did not make any difference. Final, another nail was put on this coffin of use of atorvastatin and statins. Effect of loading dose of atorvastatin prior to planned percutaneous intervention on major adverse cardiovascular event in acute coronary syndrome. Secure PC trial. Earlier was a thrombosis trial. This is secure PC trial. If you happen to look at the secure PC trial, the placebo and atorvastatin did not make any difference. Whether they went to PCI or they did not went to PCI, the outcome was the same. And in this set, they said the word, amongst patients with ACS with planned invasive measurement with PCI, periprocessor loading of atorvastatin did not reduce the rate of MACE in 30 days time. The findings do not support the use of a loading dose of atorvastatin among uncertain patients with ACS with intended invasive management. So these two papers published just recently, one from India and one from Europe, talking of two things, whether they are really useful in life or not. In conclusion, friends, I'll say that the current recommendations is high intensity statin therapy should be initiated or continued in all patients with non-ST elevation MI or acute coronary syndrome with no contraindication to its use. That's class 1 level of evidence as A. 1A is the indication. These trials, there are certain smaller trials are there. We need to have more trials not to use statins in the practice. It is reasonable to obtain a fasting lipid profile in patient with non-ST elevation ACS, preferably within 24 hours of a presentation, class 2, level of evidence C. And if I go to a further, it is recommended that to start high intensity therapy as early as possible, unless until there's some contraindication is there, or maintain it for longer duration. That's class 1A as per as European Heart Journal in 2018. An LDL goal of less than 70 and reduction of at least 50% of the baseline of LDL between 70 to 135 is recommended. That's what contradictory or difference of opinion is there. Some says 50%, some says 50 as a cutoff line for maintaining the LDL level. On the other hand, it is recommended to obtain a lipid profile in all STAMI patients as soon as possible after presentation. And if the patient LDL cholesterol level is more than 70 mg/% despite maximal tolerated doses, remain at a high risk. Further therapy to reduce LDL cholesterol by not using other drug like azitamide or the PCSK9 inhibitors, as we discussed yesterday for last couple of days. And finally, atherosclerotic cardiovascular disease category is AACE and ES lipid guidelines 2017 also said the same thing. If you have an established clinical cardiovascular disease with patients with diabetes, CKD or heart failure, LDL level is same 55, and on top of that, if you have a established recent hospitalization for ACS, coronary or carotid peripheral vascular disease, LDL level should be maintained as 70 in these very high risk of groups. So friends, if you really ask me, they are the drug of choice. Load as early as possible, continue as long as possible to make the level to come down to 50 or the 50% of the initial doses. And discontinue only when there is substantial evidence of those 4 things which we talked earlier over here. I have one personal point is high intensity therapy with both statin and non-static drugs are need of the hour in ACS to bring down LDL level to at least 50% milligrams or less. We should not only aim at plaque stabilization but also in plaque regression, where possibly the rosuvastatin scores over atorvastatin. I have a reason to say these kind of a word, and you must have seen in your practice. If I have got a patient with acute coronary syndrome, if I do a vessel angioplasty, a culprit vessel angioplasty in that patient who had a triple vessel disease, other lesions are 40, 50 or 60% lesion, and we deal with a 70% or more lesion. What happens after 1 year or 2 years, 3 years? These people, they come back with the same patient presenting with another artery lesions. We are only dealing with the plaque stabilization. We are not talking about plaque regressions. And in diabetic population, all of us knows we have a multiple lesions or coronary vessels when we subject these people for emergency angioplasty. And if we happen to use rosuvastatin instead of an atorvastatin, possibly we will not only be doing a plaque stabilization, maybe we also be doing a plaque regression also in this subset of population. Although large trials are needed to prove this point of mine, where academic institution with industry can work together. Thank you very much for your patience here.